Hello everyone and welcome to today's Scottish Drugs Forum webinar. I'm Dave Little, CEO of SDF, and I'll be chairing today's session. The session will run no later than 2:15. The aim of the webinar is to launch the National Wound Care Guide, which has been published by Scottish Drugs Forum. Work on this guide has been undertaken by Sophie Given, who formerly worked with SDF in a Preventing Bacterial Infections post, and Alison Cool, who is a specialist nurse in Edinburgh's harm reduction team and a lecturer at Queen Margaret University. Both Sophie and Alison will speak today and provide background to the guide and detail of the guide itself. In addition to Sophie and Alison, we will also hear from Norma Westland, who oversees the bacterial infection work within SDF, and John Campbell, NHS Greater Glasgow and Clyde. Norma will talk briefly about wound care activity currently across Scotland, and John Campbell will describe work being delivered in Glasgow as part of the WAND initiative. The presentations will be followed by a question and answer session. So let's get started with our first presentation from Sophie Given, who is, as I said, previously worked with SDF and is now Operations Manager at University Hospitals Bristol and Western NHS Foundation Trust.
Good morning and welcome to my presentation on bacterial infections and harm reduction. I'll be focusing on maintaining services where barriers exist. My name is Sophie Given and I'm a co-chair of the infection subgroup at the International Society of Addiction Medicine. In my day job, I'm a matron, but I've recently been working as a harm reduction lead within Scotland and as an infection prevention and control nurse during the pandemic. There's been no greater barrier than that of COVID-19, which has presented serious challenges for delivering services for people who use drugs. The treatment of bacterial infections has been no different, given that effective prevention and treatment requires face-to-face services. Today I will give an overview of harm reduction in Scotland, bacterial infections, what are they and how much of a problem they are, as well as talking about barriers to accessing these services in the post-pandemic era and explaining how some of these barriers are not new. I will then look back at some of the initiatives introduced in Scotland to tackle gaps in harm reduction during the pandemic, and finally I will introduce a national wound care resource aimed at improving accessibility and access to wound care, advice and treatment within Scotland, but which is adaptable worldwide. For the purposes of this presentation, I will be using the following definition of harm reduction, which is used within Scotland. It has been drawn from the UK Harm Reduction Alliance and states that harm reduction is a term that defines policies, programmes and services and actions that work to reduce the health, social and economic harms to individuals and society that are associated with the use of drugs. What does harm reduction look like in Scotland? Well, a few examples of this are injecting equipment and provision services. These services can be pharmacy-based or enhanced services which offer specific harm reduction services like those for image performance and enhancement drugs, wound care and medicated assisted treatment. Due to the rural nature of Scotland, we spread out quite far. We also offer outreach services which bring services to the individual. Drug-related harm since the 1980s has predominantly focused on bloodborne viruses. However, bacterial infections amongst people who use drugs are becoming more and more common, as well as outbreaks of certain types of bacteria within the population. So why has there been minimal focus on bacterial infections? Well, for HIV and hepatitis C, we now have good treatment options within many parts of the world. However, effective prevention of treatment of bacterial infection requires a robust harm reduction model, accessible services and access to healthcare. This requires large-scale service provision, which can be difficult to implement and costly. Research suggests that one of the most common reasons for hospital admissions amongst people who use drugs is as a result of soft skin and tissue infections, as well as bacterial infections. Therefore, adopting a preventative harm reduction has benefit to the individual and to society. So let's look at some facts. Hepatitis C in global studies suggest up to 25%, around 1 in 4 people who inject drugs are chronically infected with hepatitis C. For HIV, that's around 1% of people who use drugs are living with HIV. If we're talking in the context of Scotland, this has increased recently to 3.8% of the population in Glasgow as a result of an ongoing outbreak from 2011 to present. But for bacterial infections, 1 in 3 people who inject drugs report a skin and soft tissue infection in the past year, which then puts the likelihood of having a bacterial infection to be much greater. Global studies estimate that the lifetime prevalence of bacterial infections is between 50 and 70%. So what are bacterial infections? Bacterial infections in the simplistic terms. There are millions of bacteria that live all around us and live harmlessly, often making up the body's natural defence and natural flora and helping us live healthy lives. Only 1% of all bacteria pose a threat, and for most people, this threat is minimal if living a healthy lifestyle. But for people who use drugs, there's a significantly higher risk of having severe bacterial infections for a variety of reasons, including poorer health, weakened immune system, poor diet, and poor living conditions. And then simply through the act of breaking a barrier in the body's natural defence, which is the skin. Injecting with unsterile equipment and a lack of sterility of street drugs can result in a high incidence of infections amongst people who use drugs. Wounds are very common due to frequent injection, use of blunt equipment, and use of acidifier, too much acidifier, and types of drugs. Wounds then create the perfect environment for bacterial growth. Combine this with limited access to wound care services for a variety of different reasons, including stigma, we then create what can potentially be the perfect storm for very severe infection. So I spent a few years delivering bacterial infection training as part of a harm reduction approach in Scotland, and I really found it difficult to try and help people understand bacterial infections just because it's something that's not been talked about a great deal. And I found that it's really important to actually differentiate two different types of bacterial infections so that people can tailor the harm reduction to the specific needs of the population. So things become even more complicated in the harm reduction world when we're talking about splitting these bacterial infections, because we can split them into spore forming and non-spore forming bacteria, both of which are a common threat to people who use drugs. I try to think of these two bacteria types as one with a hard shell, which is my spore forming bacteria, and this hard shell offers protection and makes it resilient. We then have one without a shell, which is your non-spore forming bacteria. And the one without the hard shell can be easily destroyed and has limited protection, but is more commonly found. Infections with spore forming bacteria, these can range from tetanus, botulism, and anthrax, and are predominantly caused by contaminated drugs. These infections become life-threatening and can become life-threatening and can require urgent medical attention. Education is key in tackling these infections, especially in times of outbreak. And in the past in Scotland, when we've had outbreak, that's been one of our big public health messages, is spreading what this type of infection is and to identify the signs and symptoms of this infection so that people can seek treatment and help. A practical harm reduction approach is offering alternatives to injecting drugs when we have these types of spore-forming bacterial infectious outbreaks. Unsterile injection practices, sharing and reusing equipment are most commonly associated with the non-spore forming bacterial infections, so the ones without the shell. These are the ones that you've probably more commonly heard of, such as Staphylococcus aureus and Group A streptococci, which are often worsened by poor wound care and delays in seeking healthcare. So just to give you a few facts about both of them. So spore-forming bacteria, as I said, this is the one with the shell, and these have endospores present. They're most commonly found in contaminated drugs. An example of this was an anthrax outbreak that we had in Scotland with contaminated drugs. They're bacteria which are uncommon to the UK. There's very little chance of natural transmission. They're very tough, and treatment often requires an antitoxin to be given. Non-spore forming bacteria are found all around us, and they can be part of the natural flora of the body, and they're found in our skin, nose and mouth, and they can be easily destroyed, but we can also pass them to person. So as you see here, they're very different in terms of how we would offer harm reduction advice. So when I was looking at giving some facts and figures for this presentation, I wanted to look at beyond Scotland and see what was out there. And it's really difficult to give a prevalence of bacterial infections globally or even within Europe because a lot of this goes unreported. In Scotland, we're fortunate to have the Needle Exchange Surveillance Initiative, which does capture some information around bacterial infections. Another thing is that we've had some big, large-scale outbreaks in recent years, so I'm going to just touch base on a few of them now. So in approximately the last 10 years, we've had widespread outbreak in Scotland amongst people who use drugs of Group A strep, which is the non-spore forming bacteria, and botulism and anthrax, which is a spore forming bacteria. We've had others, but these are notable just for the amount of people that were affected by them. In all of these instances, harm reduction services have been vitally important in spreading the messages, mostly around identifying symptoms and helping individuals access treatment and services. However, it's not just outbreaks that are of concern, and I'm going to show you two graphs which show a trend in bacterial infections amongst people who use drugs. So this UK surveillance of bacterial infections show that there has been a year-on-year increase in both methicillin-resistant Staphylococcus aureus, so your MRSA, and methicillin-sensitive Staphylococcus aureus, so your MSSA bacteremias. If these bacteria are left untreated, they can become systemic infections, especially through the nature of breaking the barrier into the body, so the skin, as I've previously mentioned, and can go on to cause life-threatening conditions such as sepsis. So an example, in 2019, there were 50 MRSA and 459 MSSA bacteremias amongst people who inject drugs. There's been an increase in the proportion of MRSA cases for which injecting drug use has been a factor over the last 9 years, and I think this graph really represents that increase and shows it very, very well. However, the number of cases associated with injecting drug use for both MRSA and MSSA are likely to be an underestimation, and that's what I've previously touched on about all different types of bacterial infection, that we just don't have the surveillance. In Scotland, really, although we do have a good surveillance initiative, we still know that some are not counted within this data. In Scotland, 11% of all bacteremias reported are from people who inject drugs. So this graph is from the Shooting Up report, and this is for MRSA, and the graph on the following page represents MSSA. So I'll just turn to that now. So this is our MSSA. As you see, it's a very similar trend, and so it's something that we are starting to put a bit of focus on within the UK, as we know that this trend isn't going away, and the amount of hospital admissions that we get out of these types of bacteremias is on the up as well. So what can we do, and what are we doing? So infection risk amongst people who inject drugs is amplified by structural barriers related to accessing testing, care and treatment, and this is because of homelessness, imprisonment and discrimination. So public health surveillance of infections and diseases and associated risks and behaviours provide information to help us understand the characteristics of people who inject drugs in a population, but there's much more that we need to do. We know about the frequency of these infections, we know about the risk factors for them. So how do we tailor services to make them more accessible and to make them, more accessible, but ultimately allow for people to access them and try reduce the amount of infections that we see within the UK and within the world relating to bacteria. So examples, the first one, route transmission. So route transmission is encouraging people who use drugs to transition away from harmful injecting drug use to less harmful methods such as administration via smoking or rectal administration. Access to clean injecting equipment. So I'm going to go on to show you a slide in a minute which tells you about how much reusing that we estimate within Scotland, and I'm sure this is throughout the world, but we would like to ensure that everyone has access to clean injecting equipment, removing the barriers of stigma and social economic factors. And one thing that I've identified in Scotland is that our education is probably not broad enough for the amount of drug use that now takes place in the country. So education is a preventative measure, but also education when people are using drugs, and offering frequent health assessments alongside this so that people can take sort of control of their own health needs and understand the real risks in the drugs that they're using and the type of administration. And lastly, removing stigma from all of harm reduction to ensure that people who use the services are never deterred because of the fear of stigma. I feel quite passionately about this as a nurse, and have worked frontline healthcare and seen that stigma is definitely a barrier, and that the pressures on healthcare are not going away, and so the stigma alongside that is going to persist and be there. Okay, so as I mentioned, I'm going to give a real life example of how something practical in harm reduction can affect the amount of bacterial infections or the susceptibility of bacterial infections amongst people who use drugs. So for norm spore-forming bacterial infections, the one without the shell and the one that's most commonly found in the UK and in our surroundings, and the one that can be passed from person to person. Over the past 2 years in Scotland, the use of needle exchange surveillance has showed us that the prevalence of needle sharing and reusing is on the up. So if we take this as a practical example as to how this might correlate to the increase in bacterial infections, I'll run through what it could look like in Glasgow. So we estimate that there are around 7,000 injectors approximately in Glasgow city centre. If of these 7,000 injectors, I think we would agree that an average of 4 injections per day would be normal, which would equate to 28,000 injecting episodes per day. look at that over a week, that could be 196,000, and over a year, that's as much as 10 million. But yet we only distributed 1 million needles when I looked at this data. So that's a shortfall of 9 million. And you can see that then if people are reusing needles 6, 7, 8, 9 times, how the likelihood of bacterial infections and other injecting related harms, such as BBVs, is going to be prominent. When we think about the pandemic and what happened when the pandemic hit, our national access to injecting equipment was restricted, as well as access to healthcare was limited, and face-to-face interaction was all but gone. So overnight, we've had to adapt to ensure that the most vulnerable in our society were not left behind. But this is data and statistics pre-pandemic, so it is when we do now look at the data coming out of the pandemic, it will be really interesting to see if this had a big impact as well. During the pandemic, like everyone, and we had to adapt. So in Scotland, we did a few different things to try and assist people accessing services. So myself and the team at the Scottish Drugs Forum created a wound care resource and distributed this nationally along with dressings. So they were just simple dressings, and we did a massive distribution of this. And I'll show you the wound care leaflet on the next slide. Some harm reduction services in rural parts of Scotland also introduced postal injection equipment provision, and this is something that I've seen take place in rural parts of Australia before, but this was a novel idea in Scotland, and since the pandemic, we've continued this in some parts of Scotland. I also had reports of services turning to use Zoom and FaceTime and other communication tools to ensure that individuals continued to have interaction and did not feel that they were left behind. So we did a few different things, but I'm going to focus on the wound care, self-care wound care leaflet. So here is the self-care wound leaflet, and this was distributed alongside those simple and non-adherent MEPOR dressings because we recognised that prior to the pandemic there was limited access to wound care, and that this would be amplified by the reduction in face-to-face harm reduction services, including just simple services like pharmacy. So these leaflets and dressings were delivered by outreach teams. They were given with postal IEP kits, as well as being available within pharmacies and enhanced services for people who would collect injecting equipment provision. It was about making services more accessible, because this has always been the intention of harm reduction, and one could argue that a benefit of the pandemic was that it catalysed their efforts to do so. So this is one positive story and a lesson learned that we shouldn't forget, and hopefully continues. But following the wound care leaflet, it really got me thinking and others thinking that there was just very little education and advice to help harm reduction workers with identifying, managing, and offering simple treatment options to people who use drugs regarding wound care. So by creating this resource, it was hoped that we could continue to ensure that services are accessible, and that we learn from the initiatives during the pandemic, and that we show elements of progress and success and we don't go back from them. So this positive story then led on to the creation of a national wound care resource. So here is a national wound care resource, and why do we need a national wound care resource? So many people who inject drugs in the pandemic really sort of brought this to the forefront, continue to suffer from injection related wounds and injuries, but often struggle to access services. These injection-related wounds can range from simple pain at the point of injection to serious life-threatening conditions such as botulism or anthrax. Early identification of these wounds and complications is essential, as it can limit further need for medical care and response, and I've previously touched on that. So my colleague Alison Cool, who worked with me on this wound care guideline, and it was an adaptation of a wound care guideline that was already published in Canada. So we've worked on this, and she will follow my presentation and give a further overview of the wound care guide and the type of wounds most commonly seen in Scotland. Many people who inject drugs are not fully engaged with drug services, and we've identified this as a barrier, and may not have access to regular health checks. Therefore, it is vitally important that we ensure services are accessible, stigma-free, and offer informed and knowledgeable advice and wound care treatment. An example of this in Scotland is having simple wound care services available at pharmacies, where people who use drugs are collecting IEP and don't have to go out their way. Assessment of wounds can take place, as well as giving simple dressings and advice, and most importantly, ensuring on-site referral if infections are severe. My colleague John Campbell will then explore, after Alison, how a new initiative in Scotland aims to incorporate wound care advice and treatment, acknowledging how vitally important it is for health, for the health and well-being of this population. Thank you very much for listening to my presentation. I hope it has been informative, and if you have any questions, please direct them to me. Yeah, thank you very much.
Thanks. That was really a helpful presentation there from Sophie Given that sets the scene. And also Sophie mentioned that our next speaker is Alison Cool. And so we'll just hopefully set that up just now as the next contribution.
Hello, I'm Alison Cool and I'm a specialist nurse within the harm reduction team at NHS Lothian, where I lead the wound care service at Spittal Street. I'm also a lecturer in nursing at Queen Margaret University in Edinburgh. I'm going to talk about injecting injuries in Scotland just briefly and the development of this new National Wound Care Guide. People who inject drugs breach the protective layer of the skin frequently. That's no surprise to any of us, I'm sure. The needle will go through the skin layer and into the vein, and in doing so, this creates an injury. There is a high prevalence of wounds in people who inject drugs. A study done a few years ago now in Glasgow showed that 60% of people who inject had experienced wounds, and that's quite high. In the service that I work within, we see skin and soft tissue infections, we see leg ulceration, we see abscesses, and it is an abscess that's in the picture there. We're always on the lookout for more serious things. Pseudoaneurysm is one of those, and that can be mistaken for granulomas. All of these things are quite common. We do know that there is often a reluctance to approach mainstream services with visible injecting harm. People are often ashamed of perhaps poor technique or the visibility of damage and the visibility of injecting habits. The service that's run in Edinburgh is part of the addiction services and sits aside the methadone programmes, the dental service, the women's services, and offers a non-judgmental approach, a welcoming approach to people who have injuries from injecting. There are, of course, always negative attitudes towards people who use drugs. That's no surprise to anybody who will be listening to this. And often that is based on ill-informed assumptions about drug use. People who use often have feelings of shame and worthlessness, and that is engendered through stigmatisation. People often think they are not worth bothering about. They think that people think they're not worth bothering about, and all of that stigma, of course, impedes recovery and can prevent people from seeking help, especially with visible injecting injuries. We know that individuals may seek help through drug services and IEP services, and those services often ask about injecting sites or their skin, but they may lack the expertise to diagnose and treat. There may be a cursory "how are your sites?" and an individual responds they're fine, and perhaps a worker may not want to probe any further for fear of what they might disclose or see. It might be that they don't want to see the wounds or the injuries because they won't know what to do about them when they do see them. So sometimes it's better to take a safer approach and avoid the topic altogether. However, if somebody has entrusted an individual with information about the damage that they may have done, that might be the only opportunity that that person has to help them. Might be the only time that they trust enough to disclose. So it's really important that people can get timely help when they need it. Sometimes the stigma and the embarrassment may lead individuals to self-manage to crisis point and to hospitalisation, and that's something we would quite like to avoid. And people can be really creative in how they manage their own wounds when they haven't got anywhere to go for help. Not many areas have accessible wound services. Mainstream services may be quite judgmental, and people can manage their own wounds in some quite horrific and unpleasant ways. Just last week I saw somebody in my clinic who was managing their wound with a sanitary towel and some parcel tape to hold it in place, and he had been doing that for some time. With the pandemic, we realised that access to healthcare was actually going to be much more difficult for everybody, and mainstream services were quite challenged, and there was naturally reduced access. We used to have a full busy waiting room where I work, but of course we couldn't have a large number of people all in the same room inside, and we had to change our ways of working. But with this, we also identified a need for the guideline in wound care. We thought providing written and practical guidance with some colour pictures would be quite helpful, and that guideline would need to be accessible for all people who work with those who use drugs, not for specialist services in particular. So we worked on developing a guideline. It is based on work undertaken in North America by Alec Dunn and Tim Gauthier and adapted for our use in Scotland. The guidance was developed by October 2020, and there was a wide consultation last year with the guidance refined and now complete, leading to this publication by SDF. The content is quite lengthy, but it is split into sort of logical sections. We start with wound healing and assessment and some useful resources for wound assessment. We then look at common injecting injuries, peripheral vascular disease, infections and some life-threatening conditions. There are tips and practical resources in there and a glossary of terms, because you can't write a guideline like this without using some of the medical terms that might be unfamiliar to people who work within IEP services and with people who use. So the glossary is there to try and help that interpretation. This is one of the early pages in the guideline. We've tried to make the guidance quite clear with things like stuff to ask, questions to ask individuals, and sections on top tips. Our layout for each of the conditions, if you like to call them that, includes a definition, signs and symptoms, risk factors. Sometimes prevention is included there, and treatment. And this is one of the pages to do with groin sinuses that we have within the document. The guideline is quite lengthy and quite large, so it will be available online. It does make wound guidance more accessible to everybody, and it's for use by everybody who interacts with people who use and inject drugs, we hope. It brings some education and information to services where perhaps a physical healthcare service is lacking. Not many addiction services have the luxury of physical healthcare clinicians. And it's so people with a background unrelated to healthcare might be able to help people who inject drugs as a first point of contact. And with that, we would hope it would reduce some inequalities. It builds on previous work, as I said earlier, done in North America, and hopefully will be useful for everybody who works with people who inject globally, because there is nothing similar to this other than what we have encountered in North America, and that's quite specialist to that particular population. The guideline also does build on previous Scottish work that we undertook in NHS Lothian around about raising awareness of venous disease, and in particular in trying to reduce the prevalence of leg ulceration. We know that that has been rising in the injecting population, and the study I alluded to earlier about prevalence of wounds in Glasgow also revealed 15% prevalence of leg ulceration in an injecting population compared to 1% in a non-injecting population. So the prevalence is quite high. An ulceration in the leg is preceded by venous signs, thread veins, varicose veins, skin staining, ankle flare, and leg ulceration is actually end stage disease. So we developed resources in Edinburgh to try and provide more information to discourage people, if you like, from leg and groin injecting before they reach this end stage, and this information is also included within this guideline. The wound care improvement within the guideline does aim to meet the standards recommended within the MAT standards guideline published last year, where wound care is a recommendation and that people can access that as part of harm reduction services. It's also a core requirement of IEP services, so hopefully this National Wound Care Guideline will enhance the service provision to allow those recommendations to be met. I'd like to thank all the people who kindly allowed themselves to be photographed and for that image to be used in this guideline, to Alec Dunn and Tim Gauthier who commented on the guideline and produced the original North American version, to Sophie Given for the original idea, and for all the consultees for their helpful comments. Thank you.
Thanks to Alison Cool for that comprehensive presentation that along with Sophie Given's presentation, really sets the ground to the guide and what we need to do taking this forward. I'd now like to move on to Norma Westland, my colleague, who's going to give a little background on the wound care available in Scotland currently to injecting drug users. Thanks, Norma.
Hiya. I'm absolutely blown away by the number of participants we've got. It's great to see that many people that are interested in being here, and obviously it shows the timeliness of this document. What we wanted to do for this presentation was just do a whistle-stop tour of what we know is available in Scotland at the moment. So my colleague Lynn Cooper had reached out to the Scottish Needle Exchange Workers Forum to ask what provisions were available in their areas. So this quick report's based on the information we got back. It's not exhaustive, and if we've missed anybody, we're really sorry, but please let us know if there is anything that we've missed in your area. So I'm going to start with Aberdeenshire. So we're hearing that ADA and Turning Point Scotland provide visual checks of wound sites in both their static and outreach provision, IEP provision. North East have access to self-treat packs and leaflets, and they report that they've got good relationships with the NHS services for onward referral, and they'll help support people attend those appointments, which I think is absolutely vital. Tayside Hillcrest are co-located with NHS staff who can provide wound care interventions on site, and they also provide self-care kits if needed. In Fife, we are with you. I've got self-care packs and do visual checks, support onward referral, and again support people to access appointments for further assessment. Shetland Hub's really similar to Fife, but they're hoping that they're going to be co-located with NHS input and wound care nursing input in the near future. Edinburgh, Turning Point Scotland and Change Grow Live report that they give advice and signpost if needed. The Salvation Army and NIDRI do visual checks in their IEP service, and also provide self-care packs and leaflets, and they'll support people to attend further appointments, such as minor ailments and GP. Also, the people we spoke to in Edinburgh were all fully aware of Spittal Street and Alison Kill's clinic, and regularly make referrals there. In Glasgow, again, we don't think we've necessarily got a full picture of Glasgow, but the partial picture that we've been able to get, Hunter Street and the Drug Crisis Centre have nurse provision where wound care interventions are delivered. Jim Thompson's all over Glasgow, including the Simon community, where the WAND initiative's in place, and my colleague John Campbell's going to talk about the WAND initiative just shortly. And they also do Accuvein assessments to help people in their injecting technique. In the West, we are with you, and Turning Point Scotland do visual checks and onward referrals. And in North Ayrshire, there's a nurse nursing service that are doing wound care. In Forth Valley, Change, Grow, Live and Transform both do visual checks. Transform have got Selfcare packs, and the NHS have just employed a harm reduction nurse who's going to take up wound care as part of her role, as I understand it. In the borders, we are with you doing visual checks, giving advice and packs, and then referring on as need be. There's also some co-location there so people can get on-site interventions. So that's the picture we've got. And again, if we've missed anything out, apologies, but please let us know so that we can add to this map, because it's really useful to see. I think one of the things that certainly seems to work well in the people we've spoken to is co-located services. Definitely having somebody on site that can deal with something there and then is a huge advantage. I think we're seeing really great evidence, good partnership working, that seems to be vital. And I think, as Sophie was saying in her presentation, COVID's been a nightmare, but I think the fact that there's been far more assertive outreach and more creativity being shown is one of the small bonuses to kind of come from that. In chats with kind of frontline staff, a lot of staff though report that they don't feel confident in dealing with kind of wounds, and it can be intimidating, and I completely appreciate that. And I'm so grateful for this guidance, because this guidance is hopefully going to alleviate some of that anxiety and lack of confidence. With regards to further training, Scottish Drugs Forum have some e-learning available if anybody's interested. We've got How Are Your Sites, and we've got Bacterial Infection and Drug Use. As well as this, myself and my colleague Lynn can look at bespoke training for your service. If that's something that you're interested in, please just get in touch with us. I really welcome these guidelines. I think those and the recent IEP guidelines, as I said, I think they're really timely. We get a constant stream of requests for bespoke training, so there is a real need and a real interest. And I think, tying in with Matt's standard 4, it's so important that we enable people to feel confident in delivering these interventions. So that was very whistle stop. If anybody's got any questions, I'll be around at the end, and thank you so much.
Thanks very much, Norma, for that. And if people do have more information on wound care provision across the country, you can add it to the Q&A chat, and that would be helpful to us, certainly in terms of mapping what there is across the country. I'd now like to move on to our final speaker, who is John Campbell, who's going to talk about aspects of the WAND initiative. Over to you, John.
Hi, Dave. Thank you for that, and thanks for the invitation to come along to present to you today. And thanks, Norma, for the last presentation. Thanks, Norma, for the last presentation, giving an overview of exactly what's happening across the country. I was actually having a chuckle to myself when we were using the term visual checks, and I wonder what that actually involves. Is that taking a look at somebody's injecting saying, going, oh my goodness, that looks really painful, and is that the end of that process, or is that data recorded anywhere? Is it shared? Have those visual checks been used to push for low threshold access to wound first aid, for example? The reality is we've been providing injecting equipment in Scotland since mid-1980s. Over 35 years we've been providing injecting equipment, and we've been aware that for some people injecting drugs causes significant injuries and complications. But yet in all those years we've never managed to really collate any good hard data or evidence from assessments. There's so much anecdotal stuff, and I've certainly been guilty of that as well, where we tell stories about people that were injecting temazepam and ended up losing their limbs and were in a wheelchair for so many years. Now, the surveys are good. The Needle Exchange Surveillance Initiative is particularly good. along with the shooting up the port, which they feed into. So that gives us a pretty good and useful snapshot, you know, every few years about what has happened to individuals. But that's not an assessment. This is not a two-way process. That won't give the individual advice on how to reduce further injecting-related harms and complications. But I do think we have an opportunity now with the release of these guidelines and previous development of tools like the assessment injecting risk to really make a push on this. The assessment injecting risk was a tool that we started to develop back in the early part of 2018. So this was developed through a national group called the National Neo Development Group. So all areas in Scotland were represented here. All areas in Scotland contributed to this. As we were aware, there was no set assessment that we could use and we could draw on for people that were injecting drugs. The tool was developed, it was piloted, it was refined, and it's been available to all areas since 2019. But disappointingly, only 5 out of the 12 areas that have access to that in Scotland are currently using it. So this is a tool that people felt there was a need for, that helped develop, but you know, most areas have chosen not to actually use this. So there's definitely an opportunity there for us to start using it and share that data. Okay. So essentially what I want to share with you today is the assessment of injecting risk that we would use as part of the WAND initiative. The WAND initiative is an incentivised harm reduction drive that draws together 4 key harm reduction interventions. So that would be wound care, the assessment injecting risk, the provision in the naloxone, and dry blood spot testing. Now, I'm going to present data over the last 3 months for a few reasons, mainly because it's new, it's very relevant, so it's up to date. But the way we offer the WAND initiatives, we ask people to present for the WAND once every 3 months. So out of those 221 assessments, they're nearly all unique clients. 213 of them are unique clients. So I thought we'd start by looking at what we're identifying, what clients are reporting in relation to injecting-related complications. So these are the previous 6 months. 76 individuals reported missed hits. So that's evidence that people are struggling to find a vein, so they're digging about in different sites. Obviously, that's leading to abscesses, infections, or if they're damaging veins when they're digging about, it's accelerating vein collapse. And you can see 57 individuals reported collapsed or blocked veins. 24 individuals reported deep vein thrombosis, synonymous with people that are injecting into the femoral vein, unfortunately. 24 individuals reported infections, 22 abscesses, and 15 venous ulcers. So I guess you've got to ask, well, why are these complications, why are these injuries happening? So if you dig a bit deeper into the air, we start to look at the drugs that people are injecting. We actually now in Glasgow have more people in Glasgow city centre anyway, more people injecting cocaine than we do heroin. So 154 individuals reported injecting cocaine. Now what that means is people are injecting far more frequently, and the more frequently you inject, the greater the risk of complications. You can see there as well that 20 individuals had reported smoking of crack or freebase cocaine, but we would only do this assessment with people that were currently injecting. So those individuals that are smoking crack or freebase cocaine are also injecting either heroin or cocaine. So 140 individuals injecting heroin. Yeah, you might not inject as frequently, but you're far more susceptible to spore-forming bacteria outbreaks if the heroin is contaminated. We're looking at the numbers of people smoking heroin reducing as well. No surprise, I'm sure, to most people in this group, the high level of people that are using street benzodiazepines. Well, street benzodiazepines and a level of sedation that can cause as well if people are injecting. And again, we would only carry this out if people were injecting, may lead to a less controlled injecting episode and harms associated with that. And 102 prescribed methadone. So I guess what that's saying as well is there's no guarantee that if we get people into, drug treatment, ORT, then it's going to stop injecting and all those complications. look at where people prepare and inject their drugs. So the vast majority would say that either their own home or another person's home, a home of their friend. For those that inject in hostels, and the risks that were coming out there were more to do with sharing. Yeah, they could wash their hands, it was well lit, it was fairly warm. But a large percentage of this population as well injecting away from home, you know, what would probably term more public injecting, car parks, alleyways and lanes in the city centre, and, you know, enclosures or bin sheds, you know, and there you're starting to introduce significant risk. Where people are watching over their shoulder, the injection becomes far more hurried than it has to. People are often exposed to the elements, makes it difficult to raise veins, makes it difficult to see what you're doing, you know, and you can only imagine the range of complications that come with that. So here we're focusing on high risk injection sites. So we're looking at high risk as in below the waist injection. So 106 of those individuals reported injecting into the femoral vein. With every assessment, when we ask someone where they're injecting, we physically check that site wherever we can. Of course, if it's a male doing this assessment and a female, then it's not appropriate to check the femoral area. You know, you would hope they'd be able to get another female member of staff to do that, but that's not always possible. But regardless, 38 of those sites were in poor health. 49 individuals were injecting into their legs, and 31 of those individuals, when we checked their sites, were in poor health. 5 injecting into their feet, and 3 were in poor health. Okay, so scratch the surface a wee bit more and look at, you know, why these complications are so high. Well, in relation to sterility, 109 individuals did not clean their hands before they prepared their drugs for injection, and 73 did not clean their injection sites. So as Alison mentioned in her presentation, you know, by the whole nature of injection, you're risking introducing bacteria through the skin. 23 people directly share needles. Now, when we talk about this, you know, and other forums, we'll look at the risk of the transmission of blood-borne viruses. But there's also a risk if you are directly sharing needles of bacterial infections. 97 individuals reported flushing their needle and syringe out after their injection. Well, the only reason you're going to flush a needle and syringe out post-injection is if you plan to use that. So here, this is hard evidence of needle reuse, which is only going to cause complications. 81% reported sharing paraphernalia with other people, again, bacterial infection risks. And for 27 individuals, they actually had their drugs prepared for injection by somebody else, so they had very little control over that process. Okay. Okay, so we introduced just a month or so ago now the Accuvein. Don't know if people are familiar with Accuvein. If you're not, the Accuvein is a vein finder. It uses something called augmented reality, which highlights the veins that may not be visible to the human eye. It essentially lights up veins like Google Maps. It's a phenomenal device, particularly for those people that feel they can't access lower risk sites in their arms that may be using the femoral vein. So Jim over at the Simi Community Hub has used that 39 times in the past months or so with a lot of success. We have the Glasgow and Alcohol Drug Crisis service ready to start with this as well. That's one of our sites for the WAND initiative, and therefore the assessment in injecting risk. And this is currently being evaluated in partnership with the Scottish Drugs Forum and Alison Poole. Okay, I'm not going to spend too much time on this, but this is just a screenshot of some of the notes that was associated with those recent assessments where the Accuvein was used. You can see Accuvein used, clients getting into his thigh, veins identified on low risk sites. This is working. This is working. If we can identify low risk sites with an individual, then they're prepared to go away and do that. Now, the way we would use that process, we go through the full assessment of injecting risk. So by the end of that assessment, we have a really good idea of what's going on for the individual. We use the Accuvein over the lowest risk area in the arm. That highlights veins under the skin. We then give the individual a marker pen, and they mark the individual veins on that animal. We double check that with the Accuvein again, and when they leave the service, they have those marks that highlight where their accessible veins are. We ask them to report back to us and let them know if they could access them okay. Okay, but it's been a bit of a process for us. For decades, we were aware of all the complications associated with injecting drugs, but we really had a pretty poor understanding of the key drivers. And I think this was pretty much across the country. We spoke about how then the air tool was developed as a national resource. We chose to develop the WAND initiative in order to drive footfall and get as many people as possible through that assessment of injecting risk. That highlighted a lot of the evidence that I presented today. So we obviously had to respond to that. We responded to that providing wound identification and wound first aid training, and we've introduced the Accuvein, which is currently been evaluated. So it's certainly an ongoing process for us. Thank you.
Thanks a lot, John, for that. That's really helpful background to the work you've been doing in Glasgow, which is all very impressive. Can we have the Norma Westland back on screen as well, and Austin Smith, who's been looking at the questions coming in. Do you want to kick off in terms of, maybe I should start off by saying people have been asking about SDF resources, and we will put an email out to participants with the relevant web links to those, whether that's the e-learning or the self-care resources. Sorry, Austin.
I was just going to say, obviously a well-designed webinar. Quite a few of the questions that came up have been answered in the presentations. But I suppose one of the things was about cocaine use. John or anyone else, is there more detail about cocaine use, both about what's actually happening in terms of harms that people are experiencing and the mechanism for that harm? What is it about cocaine? Is it simply that people are injecting more frequently? Sorry.
Yeah, and obviously Sophie in her presentation talked about injecting 4 times a day, and obviously that's increased considerably with cocaine injectors. John, do you want to answer that specifically?
Yeah. There's a number of key ways, if you like, injecting cocaine will increase risks. One of the biggest risks, and probably the main reason we've seen such an increase in prevalence HIV amongst the cocaine injecting population, was the lowering of inhibitions, which is coupled with the desire to inject more frequently, leading to much higher risk sharing behaviour. So there, that big issue for us was, the prevalence of HIV, but more frequent injecting, is only going to lead to greater injecting related harm. So in a very short space of time, we started to see people exhausting their injecting sites, so they're experiencing vein collapse after a relatively short space of time. But the injection itself with cocaine can be quite difficult, as it starts to numb the injection sites. So we started to notice, for example, a lot of people have been injecting cocaine into the femoral vein, which is a deep vein, and it's a vein you can't see. We're experiencing so many problems because that natural feeling that we get when the needle would just go into the vein was totally numb. So that solution wouldn't make it into the vein, and it would be problematic for that individual. Yeah, so many reasons why cocaine appears to be much higher risk.
Thanks, John, for that. Norma, do you want to? Can you add anything to that?
Yeah, just that, pain's a sign that the body sends out that something's wrong. And like if you're injecting your arm, you feel pain, your instincts to kind of pull out. But if you're not getting that warning sign from your body, then that's when damage is going to get done.
Yeah. Okay. Thanks for that, Austin.
And the other question was about expanding wound care provision and the range of services involved. So how could that be done? How is that done in terms of community pharmacy or other people who might be providing that service?
John, do you want to start with that?
Yeah, well, Dave, actually, I've really mixed feelings on this. There's obviously a need for very low threshold access to wound care. And of course, there's a step before that, which is to do with wound identification. you know, which isn't difficult to train people to tell if something, you know, is not right. But there's almost a step before that as well, which is the preventative stuff, you know, and we're almost jumping right on the wound care without actually sitting going, well, why are 35 years down the line, why are so many our injecting population still experiencing, you know, such significant harm? So something has to change there as well, you know, and I do think harm since 2015, since outbreak HIV, I think it's fair to say that harm reduction has pretty much been back in the agenda, you know, but I don't really feel up until this point we've managed to shape that response properly. I think the WAND initiative, now it's been rolled out into different parts of the country, has got a potential to do that. And that would be not to look at each harm in isolation. We've been responsive for years. We had an outbreak of Clostridium novae or then anthrax, instant management teams, and we would deal with that. Then with outbreak HIV, and we would deal with that. Before that, it was hepatitis C, and we would respond to that. If we have the luxury of actually being able to sit with a client for any significant period of time, then we should be looking at all these, you know, injecting related harms and complications and trying as best as possible to put a plan in place to reduce them. So I do think a lot is about, you know, tying things together at this point.
Yeah, I was just saying that's an important point, John, in terms of looking at, you know, the person, if you like, in their entirety, and obviously the importance of earlier intervention with people's situations, so, you know, wound problems don't develop. But in terms of maybe specifically looking at the aspects of for example, WAND with wound care as part of that, how would you see that being implemented across the country?
Yeah, okay. Well, I think the first step we have to do is, you know, almost change the culture of our services where it becomes acceptable for people to talk about the fact they're injecting. You know, for years, for a lot of our services, maybe it's easier for me just to talk about Glasgow in that respect. You know, we had created a culture where, you know, if people were injecting, then for whatever reason, you know, that would often be hidden, and that is why so many complications, you know, went undetected until they became that serious that the person would end up in hospital or worse. So I think the WAND initiative, you know, particularly if we're able to roll that out in as many different areas as possible, I would really hope that would start to change the culture. You know, and if people start talking about the injecting process and everything, that all the harms that come along with that should naturally increase their knowledge and their skill level as well. And after a period of time, we should together really up our game.
Yep. So are there plans in relation to that, John? I know in terms of, obviously we've had proposals around looking at MAT standard 4 and putting WAND in OST provision, which I think is important, obviously, as well as developing WAND in more harm reduction settings as well. Is there any proposals in Glasgow to develop that or to take the WAND out with Glasgow to other parts of Scotland that you can describe at the moment, or maybe that's still in the discussion stage?
No, I mean, even if I focus in Glasgow, Dave, then there's plans in place to purchase another 2 vans, kind of medical type vans, and the idea is that they take the WAND initiative into other parts of the city, because just now our focus on the WAND initiative has been within the heart of Glasgow city centre. You know, but I would love to see our services being able to provide a better service to anyone that's injecting in that community. You know, open the doors for people to have low threshold access to not just wound care, but low threshold access to injecting equipment, to naloxone, and to blood-borne virus testing. I'm not saying these things aren't offered. They are offered if people sign up, you know, to engage with our services. So I think the next logical step, and I'm hoping the MAT standards really start to drive that, is to say, right, okay, well, let's start to engage with other people in our communities at the earliest possible stage. And that'll be a challenge, obviously.
Yep. Thanks, John. Norma, do you want to add to that?
Just a couple of things. So one of the things that we are hoping to get some data on, so we managed to give you the update on what we know is kind of happening across Scotland just now. But I think I'm really keen to find out some data from minor ailments through pharmacies to see if people are actually attending there and if pharmacies are treating people, because that's not getting kind of recorded anywhere that we can find. So we're keen to look into that, and we will pursue that. And I think, again, I've mentioned it a couple of times, co-location. I think that, you know, to kind of really deal with wounds effectively, you need clinical staff to do the prescribing component. But it's probably your third sector staff that are going to be there identifying and kind of capturing people. Matt Standard 4, I'm really hoping will go away to do it. And I think I can't praise the WAND initiative highly enough, because again, as a nurse, it's taking that holistic view. Someday it's looking at the person as a whole rather than a bloodborne virus or a wound. So yeah, I'm quietly optimistic that that Matt Standard 4 will make a difference to some of this.
Thanks, Norma. Austin, any other questions?
Yeah, well, there's a few. I should say there's some questions which are we can answer offline and get directly back to people. But there's a sort of few questions around WAND, how it's incentivised for people to take part, where it's available, and is the air tool available out with Scotland, or how do people access it?
Okay, John, I think that's yours.
Okay, no, you know, there was no assessment of injecting risk available anywhere that we could find. So we put together the National Redevelopment Group. We asked for any assessments of injecting risk that were currently used. There was nothing, you know, that was anywhere near enough depth to make a national tool out of. We then started to cast it a bit wider to the rest of the UK, and there was really nothing come back. So that's why we developed our own tool. Right, okay, I'm being perfectly honest. So when we had this, what we thought was a really good tool, but then we had problems with actually, you know, either the services offering this as often as we would like, or probably it's more accurate, as we had issues with clients actually wanting to present with this for this assessment and sit for half an hour or whatever to go through it. As you can understand, if someone's come into your service, they have the drugs on their person, they're in to get equipment they're desperate to use, and you're saying sit for half an hour and go through this with no real incentive. So we tried to turn things in its head with the WAND initiative. And we offer access to a £20 multi-purpose voucher. So people can use that voucher and just go across the road to a number of outlets and exchange it straight for cash. And we thought that would be what most people would do. And I guess a lot do that, but others don't. Others top up their mobile phone, their gas, their electric. Some buy shopping, and take a wee bit of cash back. But regardless, that incentive has really started to, well, also means enough to people that they're presenting for this. So if somebody's presenting to go through this assessment injecting risk, where you're identifying they've overdosed a number of times in the previous year, like they're injecting a number of central nervous system depressants that driving those overdoses, we're asking where they're injecting, we're checking they're injecting the sites, we can see that they're infected, and you want to maximise that opportunity when you have that individual in front of you. But what you also don't want to do then is just make that a snapshot, because a snapshot becomes out of date very quickly and it becomes nothing more than quite interesting. You want that person to present every 3 months, and that is where we will see if that in-depth discussion and that advice that we are given is making a difference.
Thanks, John, for that. Austin.
Well, there's a lot of interest in the Accuvein thing. I've seen that live myself. It's quite a dramatic thing to see. So what is the availability of that? I mean, I suppose the question is how much does it cost? But could people use it themselves, or could you have a walk-in facility where people would be able to present and use it themselves?
Good questions coming through there. Accuvein's are £5,500 each. We purchased 5 for Glasgow, our services in Glasgow City. It's accessible through the WAND initiative. So any of our sites that provide the assessment injecting risk through the WAND now offer the Accuvein as part of that. What we felt we weren't able to do was actually physically mark individuals injecting sites, but we're giving them the opportunity to see, more accessible veins, and they mark their own veins at that point. So when they leave that service, they have a good indication on and where to go. Now, I think at this point it's being evaluated, so we really want to see how effective it is. And of course, we want to see if there's any unintended consequences of that as well. But if that turns out to be low risk but very effective, then you could easily see how you would want to roll that out. But goodness, if you had a client prepared to clients, it's often we find difficult to bring into your services. If you had a client then presenting every day or two, so you could actually check their veins, and to me that's a win-win.
Thanks, John. Austin?
That's us. I think just to say, as I said, the other questions we can get back to people on very specific things, and I'll pass those questions on to the panel, and hopefully we can get back via email. Thank you.
Okay, thanks, Austin. I guess that there's we've covered this already, but maybe one last question is really around, and John has already made that point, that it's not about wound care in isolation from all the other aspects, but how do we implement this to make sure it is effective? I'll come to you first, Norma, as I was saying all the questions have gone to John. What's your thoughts on that specifically?
Well, as I've said, I'm a fan of WAND, and I know there's debates in different areas. I think what's good, I think one of the unintended consequences of WAND is that whether people are going to implement it or whether people aren't going to implement it, it's definitely made people think about it, I think, in a way that maybe hasn't been done before. So as a point of, as a point of discussion or a point of, services identifying what they could be doing, I think it's, at best it will be implemented. At worst, it's a talking point that's hopefully kind of going to raise awareness. So yeah, I mean, I think that is the way forward. It's not, it's not treating people as isolated conditions. It's treating people as a whole. And as health and social care professionals, we should be doing that regardless. And I think this just brings it all to mind.
Thanks. And I've just seen there that Sophie Given did try and get onto the Q&A, and unfortunately for technical reasons, I'm not sure how she wasn't able to join. John, over to you in terms of having the last word on this before we close.
Yeah, I mean, as I said earlier, Dave, I think we've got a really good opportunity. If other areas are looking to, provide this or a more comprehensive service, it's going to be best done in partnership. For me, that was the strength in my area. I felt very privileged to have the full support of the ADP, who would obviously not just fund it, but take that risk in providing people with rapid access to cash that did allow us to drive footfall. But then I was also privileged to have the Glasgow Alcohol and Drug Crisis Service, prepared to step up and carry out as many assessments, along with Waverley Care and Jim Thompson over at the Simon Community Hub. I think if we had started just in one site on a smaller scale, it would probably have been nowhere near as effective. So I would urge any area that is looking to do this, or even if it is to drive forward wound identification or wound first aid in their area, then partnership working would definitely be the way to go.
Okay, thanks very much for that, John. I'm going to bring the webinar to a close just now. Putting together the guide is clearly just the start, and we now need to ensure effective implementation, as we've discussed already, alongside wider issues for injecting drug users. So finally, I'd like to thank all of you for attending, and a special thanks to today's presenters for what's been a very thought-provoking session, I'm sure you'll agree. And as I've said, this will be the start of improving our response to wound care for people who inject drugs in Scotland, I certainly hope. Thanks again, and goodbye for now. Thank you.